screen is visible and I'm audible?
Yes, visible.
Yes. Thank you. So just like Dr. Abhay has already briefed, I'm going to talk on the update of non-classical congenital adrenal hyperplasia. It's a very unique topic because this is one disease which is, although very common, is often undiagnosed, and many a times the treatment guidelines are not very clear. First of all, it's not very clear who are the populations who need specific therapies and who are the ones who may not need therapies. So I'm going to try and get into this area of non-classical congenital adrenal hyperplasia and see what is the data or literature supporting the treatments and the evaluations in this aspect. So this is the outline of my talk. I'm going to talk about a little bit about pathophysiology, the epidemiology to know what is the disease burden in the community, the clinical spectrum across different age group in men and women and in boys and girls, and then evaluation, management, and a brief touch on preconceptional treatment in these patients. So congenital adrenal hyperplasia is a group of autosomal recessive disorder that is characterized by impaired cortisol synthesis, of course, the severity of which may vary, and excess adrenal androgen productions, and is mainly caused due to deficiency of one of the enzymes which is responsible for cortisol production or the enzymes responsible for adrenal steroidogenesis. So when we talk about congenital adrenal hyperplasia, we have two broad categories. One is the classical congenital adrenal hyperplasia, which is associated with the severe enzyme deficiency and presence with genital ambiguity in birth, and may be associated with salt wasting in the neonatal period when we call it salt wasting congenital adrenal hyperplasia, or only with genital ambiguity when we call it a simple virilizing congenital adrenal hyperplasia. We then have this another category of non-classical congenital adrenal hyperplasia who are not diagnosed at birth because they do not present a genital ambiguity and also are not detected on the neonatal screening, but they're usually present in later part of life, in around puberty or adolescence or adult. Again, a large part of these patients may either remain undiagnosed or may even remain asymptomatic. So I'm going to now focus on this non-classical congenital adrenal hyperplasia. Now, like I already said, this is an autosomal recessive disorder, and it comprises a spectrum of disorders from simple virilizing, from salt wasting to simple virilizing and non-congenital adrenal hyperplasia. Now, when we talk about this enzyme deficiencies, there are several enzymes which have been attributed to cause this disease, but the most common we know is the 21-alpha hydroxylase mutations. So when we talk about this 21-alpha hydroxylase mutations, now depending on the type of mutations, one could determine what is the disease the patient is likely to have. Now, those who have severe mutations like deletions or null mutations are associated with severe enzymatic deficiencies where the enzyme activity is less than 1%, and they present with severe hypercortisolemia, salt wasting crisis, and genital ambiguity. There are other mutations like 12 spice and others which have some residual enzymatic activity like up to 2 to 10%, but are associated with significant genital ambiguity. Now, the non-classical congenital adrenal are associated with, again, certain specific mutations where the enzyme deficiency is not so severe. They may have residual enzyme activity of between 20 to 70%. Thus, they may not be hypercortisolemic and may not present the genital ambiguity at birth. So depending on these mutations, so that the severity of the presentation or the clinical spectrum would vary. This is a very busy slide. I'm not going to talk on this in detail, but just a brief. Now, this is the enzyme which is going to be mutated. Thus, you have a block in the synthesis of cortisol and to some extent aldosterone, and then but then because of this deficiency, there is a negative feedback leading to stimulation of ACTH synthesis, and this ACTH leads to accumulation of precursors, which is directed in the other pathway of adrenal androgen synthesis, leading to increased androgen in these patients, which is responsible for the genital ambiguity and also later hyperandrogenemia. Now, in addition to this, there's also some backdoor pathways where there are certain enzymes leads to 11-keto-testosterone and 11-keto-dihydrotestosterone, which are also responsible for the hyperandrogenic features in these patients. Now, when you talk about non-classical congenital adrenal hyperplasia, like I already said, the cortisol deficiency is very mild or sometimes not seen, and they may not even have elevated ACTH. So here they say the adrenal hyperactivity is predominantly because of the altered enzyme kinetics, where the enzymes which are involved in androgen synthesis are stimulated, thus leading to increased adrenal androgen synthesis. There's also increased conversion of this metabolites of the adrenal steroids, which into androgens. And plus, in addition to this, because of the availability of androgens in the blood, which can be converted into estrogens, there must be an early GnRH stimulations, which leads to increased LH synthesis, and that may act on the ovary and may create a picture like a PCOS, which is like a secondary polycystic ovary like phenotype, which again contributes to these hyperandrogenic features in patients with non-classical congenital adrenal hyperplasia. So depending on the presence of hyperandrogenemia across the lifespan, one might present with these features. So those who have intra-uterine androgen exposures may present with genital ambiguity at birth, and then those in childhood, again, they may present with the precocious puberty, advanced bone age, acne, frontal balding. Mainly in puberty and adulthood is when these patients predominantly present, that is in patients with non-classical adrenal hyperplasia, present with menstrual irregularities, hirsutism, infertility, etc. Again, there will be a small percentage of, again, a large percentage of patients who may not present with any signs and symptoms and may only be diagnosed through genetic screening. So that's about the spectrum. So non-classical congenital adrenal hyperplasia is associated with 20 to 70% residual enzymatic activity. Thus, has a less severe phenotype as compared to CAH, classical CAH, and is differentiated by absence of salt-losing crises, hypoglycemia at birth, and ambiguity at birth. Now, again, when we talk about this non-classical CAH itself, again, depending on the ethnicity, there might be several different mutations. We have data on that, talking about these different mutations, which are more specific to certain ethnicities. I'm not going into detail of this, just for the information. Now let's look at what is the burden of the disease. Now, if you look at the monogenic inherited diseases, non-classical CAH is considered to be a common monogenic inherited disorders with the incidence of 1 in 500 to as high as 1 in 100 births worldwide. Now, and then although we know that there are certain ethnicities like Ascanis Jews where there's a high prevalence of this disease, but then irrespective of ethnicity, if you look at this particular study where they looked at different autosomal recessive disorder, you can see that these non-classical congenital adults have a very high prevalence as compared to other diseases like sickle cell anemia, cystic fibrosis, phenylketonuria, etc. That's talking about the disease burden of the disease. Many of the cases remain undiagnosed, especially in males. Probably that's why clinically many of the prevalence may not be really high. But if you do a and looking even at the heterozygosity, then the prevalence is going to be really high. Now, as a clinician, what we are mainly concerned is that because we know that these patients present with hyperandrogenic state, so when we are encountered with these patients with hyperandrogenemia, what is the chances of non-classical CAH being the reason for it? So I think this is kind of answered by this particular meta-analysis where they looked at what is the prevalence of non-classical CAH among patients present with the androgen excess, and then across the various studies, if you look at individual studies, it varies between 1 to as high as 9%. But overall, the prevalence is around 4.2% among patients presenting with androgen excess. So this non-classical congenital adrenal hyperplasia usually, like I said, doesn't present at birth. The symptoms ideally should not occur before 60 months of age, diagnosed in a later part of life, and many may remain asymptomatic. Now, this is a slide which talks about the clinical presentations and how, depending on the age of presentations, their concerns may be different. I'm going to come to each of this again. So let's start with the clinical presentation in girls. This is, I'm talking about prepubertal girls. So premature adrenarche is said to be the commonest presentation in girls. So these patients, so that may be one of the manifestations which might bring to the clinical attentions. Again, acne can be described before the onset of puberty. Rapid growth and increased velocity is another finding, and this is also an indication which must alert the need for treatment. And of course, if you look at the indication, the reason for diagnosis, again, family screening would lead to diagnosis in many of these cases. A small percentages may present with clitoromegaly. Now, if you come in the woman, adolescent, and in the reproductive age group women, now the clinical presentation would be something with hyperandrogenic features of hirsutism, menstrual irregularities, and acne. This could be due to the hypothalamic pituitary ovarian dysfunctions, like I said, like a secondary PCOS phenotypes, or they may present with dermatological signs of hyperandrogenism, like acne and hirsutism. So, in addition to that, in the adult women, infertility it could be the presentations, alopecia, clitoral megaly. Recently, adrenal adrenal incidentallomas are also been attributed to non-classical congenital adrenal hyperplasia. Now, if you ask what is the importance to identify this, is that we know that in these patients of adrenal incidentalloma, which is secondary to non-classical congenital adrenal hyperplasia, treating these patients with glucocorticoids would help in resolution of this disease, these incidentallomas to a large extent, and also spare them from unnecessary evaluations and surgeries. And also we know that because of the hyperandrogenic state and precocious puberty, some of these patients may end up in short stature. However, this is again not a classical description for non-classical CAH, where most of the studies say that most of them would attain their adulthood, unlike the classical congenital adrenal hyperplasia. Now, let's look at the relative prevalence of different androgen excess disorders in women referred because of clinical hyperandrogenism. Now, so this is important because we see a lot of patients presenting with menstrual irregularities. Most of them would be labeled with PCOS if not evaluated. But what is important for everybody to know that PCOS is a diagnosis of exclusion. So it's important that we diagnose other hyperandrogenic causes, one of which is non-classical congenital adrenal hyperplasia. You must also exclude androgen secreting tumors, hyperprolactinemia, hypothyroidism before labeling PCOS. So just just based on an ultrasound finding or only testosterone, one should not make a confirmed diagnosis of PCOS. So in this particular study, they looked at what are the different disorders which can present with clinical hyperandrogenism. So you can see that non-classical congenital hyperplasia attributed to 4.3% of the patients who presented with hyperandrogenism. Of course, polycystic ovary was attributed to majority of patients of around 71%, followed by idiopathic hyperandrogenism, idiopathic hirsutisms. Of course, androgen secreting tumors we know is very rare. But if you look at biochemically, what stands out is that unlike if you compare to PCOS, all the androgen level, whether it's total testosterone, free testosterone, and of course 17-hydroxyprogesterones are higher in non-classical CAH. DAH, there's not much of variations between PCOS and non-classical CAH. So if you find a slightly elevated testosterone and free testosterone, that might be one of the indicators. Of course, 17-hydroxyprogesterone we know is the most important test for screening. Now, what is the chances of seeing polycystic ovary polycystic ovarian morphology and ultrasound in non-classical CAH was again looked in this study, and that among the patients who had polycystic appearance, 31% of the patients with 31% was patients with non-classical CAH. Sorry, 77% of the patients with non-classical CAH had polycystic ovaries, and 91% of the patients with classical polycystic ovaries had polycystic appearance on ultrasound. But whereas the ovarian size and was not really the main finding, because only half of the patients with both non-classical CAH and classical PCOS had increased ovarian size. So, another problem in patients of reproductive age group or in adult women with subfertility or infertility, the prevalence varies between 5 to 11% in different studies. There's also reports of increased miscarriages among patients with non-classical CAH, and also some data showing that those treated with the glucocorticoids, the miscarriage rates were lower. But again, here there's also a referral bias, because these patients who were treated were basically those who were severely symptomatic with menstrual disturbances and also infertility. So whether it applies to all patients of non-classical CAH is questionable, but of course, in those patients who had problems and had treated with glucocorticoid showed less miscarriage rate in these subgroups. Now, the mechanism of subfertility, the important cause which is attributed is to anovulation in these patients, which is most evident because studies where they've used ovulation induction have shown very good positive outcome in these patients. Now, this infertility is also attributed to persistent elevated progesterone concentrations, which is due to both progesterone and 17-hydroxyprogesterones, which results in an unfavorable cervical mucus and a persistent decidualized or a hypo and an atrophic endometrium. So next, that's about presentation in women. If you look at the presentation in men, like I said, this is it is very rarely diagnosed or very often missed in men. The most commonest form in which these people are diagnosed is when they do a genetic counsel and a family screening. But again, a small percentage in the boys, the presenting feature could be with premature adrenarche, increased growth velocity, acne, and there are few case reports on prepubertal boys presenting with gynecomastia, where evaluations, especially with family history, would lead to a suspicion of non-classical CAH and was confirmed by biochemical evaluations. So in adult men, again, presentations would be through acne, adrenal incidentoma, like I already discussed in women, and infertility is also described. Again, we do not have enough data in these aspects. Testicular adrenal rest tumors are well-defined entity in classical congenital hyperplasia. So similar hypothesis has been explained in non-classical congenital adrenal hyperplasia, but there is not enough data to look at this prevalence. So that's about the clinical presentation of non-classical CAH among the different spectrum. Now, algorithm for the diagnosis would be that, first of all, if this algorithm is mostly focusing for women of reproductive age group, those who present with hyperandrogenic features, or in adolescent girls who present with hyperandrogenic features. So like I already said, we need to rule out other causes, or we have to look at basically all the conditions which will present with the secondary PCOS, like features like Cushing's, androgen secreting adrenal and ovarian tumors, etc. In the differential diagnosis, in addition to non-classical congenital adrenal hyperplasia. So for the screening of non-classical congenital adrenal hyperplasia, one need to do a basal 17-hydroxyprogesterone, which again we have different cutoffs. If it is less than 2 nanogram per ml, that would exclude a diagnosis. More than 10 would confirm the diagnosis. Now, 2 to 10 is an area where it's just a gray zone, and probably would need that's a gray zone where one would need a post-entropy stimulation test. If stimulated value is more than 10 nanogram per milliliter, that would also lead to a diagnosis of non-classical congenital adrenal hyperplasia, which could be further confirmed by a genotyping to look at the underlying genetic mutation. So it's clear about that's the important test here is the 17-hydroxyprogesterone. And what is important for to remember is that the sample for 17-hydroxyprogesterone is to be taken in the morning and in the follicular phase in menstruating women, because the luteal phase values may overlap with normal women, hence may confuse the picture. Hence is recommended to measure it in the follicular phase. Now, if you look at the assays, again, immunoassays are the one which are commonly used throughout the country, but then the liquid chromatography, mass spectroscopy is slowly coming into the picture, of course, and it's more specific when we talk about steroid assays. The challenge would be that even if it starts available, it requires standardizations, and the cutoffs would be lower as compared to immunoassays. But that would be something one would look forward to in the coming years. And then you also have this complete steroid profiles. Again, this is helpful not only to confirm the diagnosis of 21-alpha hydroxylase, which is the commonest mutation, but also say where it is not, suppose your 17-OHP is not elevated up to the mark, but clinically you're suspecting CAH, there could be other enzymatic deficiencies, 11-beta hydroxylase, 3-beta HSD2, and P450 oxidoreductase deficiency, which could be pointed out in the steroid profile. So what are the common enzymes which is looked upon in this commercially available steroid profile is 17-hydroxyprogesterone, cortisol, 11-deoxycorticosterone, deoxycortisol, pregnenolone, DHEAs, and androstenedione. So you have a battery of several of these steroid hormones analyzed. You also have steroid and serum and urinary profiles, but again, it is not widely available, but something which might be more easily available in the future, or one would look up to it to be available in the later times. Next, coming to the management of patients with congenital adrenal hyperplasia. Now, the most important question when we talk about management is, first and foremost, suppose somebody is diagnosed with clinical presentation, if somebody is presenting with a symptom, maybe then we would consider offering treatment. The question arises if somebody is diagnosed through a family screening and is not symptomatic. So that is a challenge. So what has come up in many of the studies and have highlighted is that it's not necessary to treat all patients who are diagnosed with non-classical congenital adrenal hyperplasia if the clinical situation does not warrant it. If they're not symptomatic, then it's probably not. So those patients may not need it. So what's the most important thing to identify is that the particular patients needs treatment. And then if you're considered to start the patient on therapy, what is the forms of therapies you have? So of course, theoretically, we know that these patients have cortisol deficiencies and which may not be like a clinically obvious presentations, but that would be leading to increased stage drive and the further presentation. So theoretically, we know that glucocorticoid supplementations would be the main modality of treatment. But then oral contraceptives, that is estrogen progesterone combinations, anti-androgens, have also shown to be beneficial and equally effective in patients in the reproductive age group, mainly for the hyperandrogenic symptoms. I'm going to come to it later. And cyclical progesterones have also been one of the treatment modality. Now let's look at the management in the age-wise, like how I presented age-wise the clinical spectrum. I'll just quickly take you through this management in different age groups. So during childhood, the indications of treatment would be predominantly if one presents with accelerated growth and advanced bone age, or if they are presenting with exaggerated episodes of fatigue or suggestive of a hypocortisolic symptoms, which we usually do not expect in a non-classical congenital adrenal hyperplasia. But what we must remember is that this classical and non-classical congenital adrenal hyperplasia, we know is a spectrum of a same disorder. So sometimes it's difficult to draw a line. So if you have a patient who is having symptoms during stress, then those are the patients you need to consider therapy. At least, of course, steroid stress protocol would definitely be needed. And then if you have a patient who stimulates, if the synactin stimulated cortisol is less than 80 nanogram per ml, again, there's also patients one would consider for treatment. But otherwise, other presentations would be that if somebody is a very bothering hirsutism, acne, clitoromegaly, then again, one would consider treatment in this group of patients. During childhood, the aim is to suppress the adrenal androgens and prevent rapid advancement of bone age that could affect the final height. The drug the steroid which is used in children, we know, is the hydrocortisone at doses of 100 to 15 milligram per millimeter square. But lower doses can also be used and is found to be effective as low as 6 milligram per meter square per day. Now, the other drugs which have been used mainly when one is concerned about the height is GnRH analog, especially in those where, because of the excess androgens, there is an early activation of the GnRH axis, leading to a central precocity. So in those patients, one may consider giving GnRH analog therapy. Now, coming to the adolescence management, here the clinical presentations, like I said, would predominantly be with hirsutism, menstrualitis, etc. And in prepubertal age group, again, accelerated bone age advancement or accelerated growth would be a concern. Menstrual irregularities, some of the patients may have severe oligomenorrhea and secondary amenorrhea. Again, these are the indications for treatment. So, here, what is important for us to understand is that in patients, especially after puberty, one is concerned about relieving the symptoms of hyperandrogenemia and not really on the growth. So in these patients, again, what studies have shown that using an anti-estrogen progesterone combinations like an oral contraceptives and anti-androgens would help in the predominant hyperandrogenic symptoms and would be similar to glucocorticoids or sometimes even better. But one is looking at infertility as a major problem, or if they have very severe symptoms of hyperandrogenism, then definitely glucocorticoids are beneficial. In these categories who have completed growth, longer acting steroids like prednisolone would be preferred. Of course, there are a small group of experts who also recommend dexamethasone, but commonly prednisolone is the recommended one during adolescence after completing the growth. Now, coming to management in women. Now, again, like I already said, if hyperandrogenic symptoms are the predominant concern, one could use either glucocorticoids or estrogen, progesterone, or anti-androgens. But if somebody has having fertility issues, infertility is a major concern, then these patients would definitely benefit from glucocorticoids. Again, those would not still respond to glucocorticoid, would benefit for ovulation induction therapies. So in men, again, like I said, first of all, diagnosis is often missed. And so many of the patients may not need therapy. Some of the indications which have been suggested is if there is testicular adrenal rest tumors, fertility issues, severe acne, or there are symptoms of hypercortisolemia during stress, or a stimulated cortisol is less than 18 nanogram per ml, one would consider treatment. This would be a small percentage of patients. Again, we do not have enough data in this direction. So this is an algorithm which kind of revises all this. So if you have a patient with if you have an individual diagnosed with non-classical CAH, I would not call a patient, and if they're not symptomatic, then these patients these individuals may not need treatment and would just follow up these individuals. Those in childhood present with accelerated growth, one would consider hydrocortisone. Those who present with clinical hyperandrogenic features, you can either consider hydrocortisone or anti-androgens oral contraceptive pills. But in patients presenting with infertility, again, would prefer to use glucocorticoids or an ovulation induction if required. In pregnancy, again, if somebody is already on glucocorticoids, hydrocortisone is the preferred choice. And risk of adrenal insufficiency, again, risk of adrenal insufficiency is not really a problem, is not of a concern for non-classical CAH, because menopausal deficiency is not that severe. But if the patient is already on a long-term glucocorticoid treatment, then we know that during stressful illness, if you do not if you do not give a stress dose of glucocorticoids, then one might end up in adrenal insufficiency. So and then finally, about this fertility planning, I think I've already spoken about it. Glucocorticoids have shown to improve fertility, probably by lowering adrenal androgens and progesterones, which mainly impairs ovulations and endometrial receptiveness. So in fertility planning, in addition to this treatment, which could create a favorable environment for in terms of ovulations or the endometrial receptiveness, in addition to this, another important area one must focus on is the genetic testing of the prospective parents to assess the risk of the classical form, of the risk of having a classical congenital adrenal hyperplasia in the newborn. Now, what is the risk? Now, if you look at the data, they say the predicted chances of parents giving birth to a child with a classical congenital adrenal hyperplasia is 1 in 120 if the paternal genotype is not known, 0 if the father has no relevant mutations, and 1 in 4 if the father has a heterozygous mutation. So knowing only the mother's genotype would not be helpful. It's important that we know both the parents' genotype, and also what is the type of mutation also determines the severity of illness in the newborn. Now, so there are again a good number of studies available in this direction. This was an interesting, a good review article which have described the different mutations which has been associated with classical and non-classical CAH. So you have this mutations which are associated with classical CAH, and then you have mutations with non-classical CAH. So when you do a genotype, one could know whether the mother carries a non-classical, the genotype which is a severe, was a less severe form of like a non-classical CAH, or a classical, or one mutations which are most likely to be severe. And then if you have the father's genotype, then you could think of the prenatal treatment and etc. For example, if the mother is a heterozygous for a less severe phenotype of a non-classical, and is also a carrier of a phenotype which is associated with the severe enzymatic deficiencies, and even if you do not know the father's genotype, then there is a high risk of classical CAH in the child, that would need fetal sampling, prenatal treatment, etc. in this child. Similarly, if the father and both father are having non-classical mutations, then probably there is nothing to worry. But if the father is heterozygous for a classical CAH mutations, and mother is having non-classical and classical heterozygosity, then again these are the patients who would benefit from prenatal treatment. So this genetic testing this genetic analysis in this area is again improved a lot, and we do have a good amount of literature in this area. So this uncertainty about prenatal treatment still exists, but then of course if this area widens and we get more evidences, probably that area then there might be more light in this direction in the future. So pre-treatment treatment of CAH has been a controversial area. It's long and still remains controversial. Now, the aim is to prevent genital virilization of the fetus, especially if there is a high risk of having a classical CAH in the fetus. Now, the concern is that to prevent virilizations, the treatment has to be started as early as soon as the pregnancy is confirmed. And then if you look at the risk of the fetus, it would be 1 out of 8 because we are mainly whenever we treated glucocorticoids, what the main thing we are going to do is to suppress the fetal ACTH secretion and decrease adrenal androgens. So this is only going to reduce the fetal hyperandrogenemia and thus reduce genital ambiguity. So this is something that's important for us to explain to the patients, that they're not going to actually treat the disease but only reduce the genital ambiguity in the child. Now, to do this, we'll have to probably treat 8 fetuses. Out of it, only one might be actually being affected. So that's, we will be probably subjecting 7 of them who probably would not need therapies. So this area is still controversial with limited data. So it's very important that the risk benefit is explained to the patient and the written informed consent is obtained. And also it's suggested that it should be done after the institutional review board ethics committee of the institution approval is obtained. Now, a small hope in this area has been that the concept of obtaining a cell-free fetal DNA from the maternal plasma, because this would allow determination of fetal gender and the diagnosis of CAH at an early gestational age of less than 9 weeks, plus it's a non-invasive procedure. So this is a new addition in this area. Next comes to, once you diagnose and treat, how do you follow up these patients? Of course, so this would depend on what is the age of diagnosis. In children, one is mainly concerned about growth. So we would have to probably follow up every between 3 to 12 months, depending on the symptoms. We look at growth velocities, weight, pressure, bone age. If you look at the biochemical parameters which are monitored, it should include 17-hydroxyprogesterone, androstenedione, testosterone, and SHBG. In adults, one would basically look for weight, blood pressures. Biochemically, again, 17-hydroxyprogesterone, androstenedione, testosterone, SHBG. Metabolically monitoring would also become important. Bone health assessment, and in men, testicular ultrasound once in 5 years would also be needed as during the follow-up. So that's about the follow-up. So what are the future perspectives, and what can we expect further advancement in the futures? Like I already said, when we talk about the diagnostics, liquid chromatography mass spectrometry is a gold standard when we're talking about steroid assays. It's as of now, immunoassay is the one which is done in the majority of places. So this would be the liquid chromatography mass spectrometry is something which would broaden this area and would be more helpful, as we know it's more specific, and you also simultaneously can assess more molecules. With respect to therapeutics, newer drugs that stimulate physiological glucocorticoid secretions or provide ease of delivery there are certain molecules which are investigations. These are mainly studied for classical congenital adrenal hyperplasias like chronocort, which is a modified release formulations of hydrocortisone, and then which should reduce the frequency of administrations. And then you have the corticotropin releasing factor receptor antagonists, again, which are under investigations. Subcutaneous hydrocortisone therapy, mainly for which is approved, mainly came for primary adrenal insufficiency, but again, this is another molecule which are under investigation for CAH. And then arbiterone acetate, which is a P450 mutation enzyme inhibitor, which is predominantly used in CA prostate, has also been under investigation to use in patients with congenital adrenal hyperplasias. So these are different molecules which are under pipeline for this particular indications. I think with this, I would come to the end of my talk. I would be happy to answer if there are any questions.
Thank you, Sahana. It's a nice and beautiful presentation. You have discussed about the pathophysiology, what is the classical clinical features at the different stages of life, and also simultaneously what is the prenatal screening, and also how you are going to treat during the prenatal phase. You have discussed very aptly. And any questions? Actually, I have not got any questions in the chat box. And for our, actually, specifically those who are endocrine students, for them, actually, we know that those who are having a level between 2 to 10, 17 OSP between 2 to 10, a lot of the times in India now, this cosintropin or synactin is not available. So can, like what classically there are few papers with which that actin has been used in some cases. Can this be used in those group of patients?
Yes, yes. Actually, I was supposed to mention it. I think I missed it. So we do not have actually literature to support it for use in CAH as such, but then we have data for use in adrenal insufficiency, both primary and secondary adrenal insufficiency. So I think we could use the same so actum prolongatum, whatever, using like 25 units IM and post 160 minutes stimulated cortisol level.
Thank you. And another thing is those who are PCO patients, because you have discussed that majority of the people have like a phenotype of PCO and also the ultrasound can show PCO. So who are the subgroup of people where you will think or will suspect that these people might have CAH and I should expose those people or I should do all those parameters or CAH tests in those group of patients? What are the classical PCO patients phenotypes where you will suspect CAH?
Yes. So yes, so definitely that's a very good question, because that's a common scenario what we face. But if you actually go and see the literature, it's very difficult to kind of completely exclude CAH for any presentation of PCOS, because they say the presentations could be very mild. They could only present with hirsutism. They could only present with menstrual irritability. However, if you have a patient who has more severe hyperandrogenism, has clitoromegaly, have higher androgen levels, those patients we must definitely exclude CAH. If they have fertility issues, then those patients we must definitely exclude CAH. But then even in milder cases, suppose, for example, again, suppose if you have not, patient has presented with menstrual irregularity and infertility is not the major concern, and there's not much of an clitoromegaly or his hyperandrogenic features, then even if you have not, ideally we have to screen for CAH because we cannot otherwise exclude. But even if you have not screened for it, I think, and we are planning to treat them with estrogen, estrogen and progesterone combination, that is still okay, because even otherwise the management they say is for hyperandrogenic symptoms, there is not much of a difference between two entities. If they're not responding very well, then probably we have to consider the analysis for CAH, non-classical CAH.
Yeah. Thank you, Sahana. And another, some of the male actually develop gynecomastia. What is the basic pathophysiology of gynecomastia and non-classical CAH?
So that is because of the peripheral aromatization of the androgens is one of the postulate that has been described. I'm not sure if there is any other, but that's the one I've come across. So again, these are very few cases which are basically as a case reports what has been reported in literature, where a few prepubertal boys are presented with gynecomastia.
Thank you. Thank you, Sahana.
Can I just make one comment on that?
Yeah.
Very nice talk, Sahana.
Thank you.
Only one thing, when I mean the differentiation from PCOS, how far we should investigate each and every case of PCOS to, one point somehow came to my mind that there is literature saying that about 1/3 of these cases have some cortisol deficiency under stress. So is it, should we go for, ACTH stimulation in each and every case? Not only for the, diagnosis, I mean, not only for treatment of this hirsutism or whatever to diagnose, but to unearth this cortisol deficiency which may be there, so that, at the time of stress, maybe we may have to supplement them. That is still, I don't know how practical this will be, and because even this ACTH availability is also a big problem. So, because if we see that they are deficient in cortisol, and then probably these are the cases, even though we may be treating with anti-androgens alone, at the time of stress, we may think of supplementing them with glucocorticoids.
Sure. Yes, ma'am. If they're severe enough to have cortisol deficiency, then they also will have hyperandrogenic features, which are usually more severe than the regular PCOS. Yeah, so yes. Maybe that would be the clue, and then that time probably we should definitely go and screen with 17-OHP in addition to cortisol. And then, of course, for those patients, glucocorticoid therapy would be more beneficial than the OC pills.
Yes.